And for the people online or watching this after the fact, make sure you email me for a quiz in order to get credit. If you're here, make sure you sign in, and for New Jersey, also sign back out, and pick up both a feedback form and then fill it out, and then pick up a certificate. We'll get started, and if you haven't signed in, just make sure you do before you leave. So today we have Dr. Kristen Topping. She went to Cedar Crest College, and then she went for her doctorate in physical therapy at Thomas Jefferson University, one of those Philadelphia schools. She directs the St. Luke's Outpatient Neuro Rehab Center at 8th Avenue, and she's been with St. Luke's for a while.
6 years.
6 years. So without further ado, she's going to present today about a comprehensive approach to rehabilitation after lower extremity amputation. I'm just going to make sure everything's set. And there you go.
Thank you for that introduction, Steve. So like Steve said, my name is Kristen Topping. I am a physical therapist. I've had some mentoring and training and treating patients with amputations. I did a clinical down at Bryn Mawr where I had some opportunity there, and then also here I've been working with our colleagues in the outpatient environment as well as the inpatient environment to kind of come up with a system for best practices and how we want to approach the treatment for patients after their lower extremity amputation. So this presentation is going to give us a little bit of an overview of the current barriers that we're facing within our network with treating this patient population. It will help us recognize the healthcare professionals that are an integral part for the development of this comprehensive care program and for treating these patients after lower extremity amputation. We're also going to discuss the different stages of lower extremity amputations so we can provide the appropriate interventions and referral for additional management strategies for other healthcare providers, and then identify the necessary patient education and interventions to provide the best continuity of care throughout the post-amputation period based on the differential diagnoses, so different things that your patients may need. So to start off with some statistics, there are about 2 million people in the United States with lower extremity amputations. 54% of this is due to a vascular issue. Most of the amputations that we're seeing in our hospital system and in outpatients are from our vascular doctors. So these are issues like diabetic complications or peripheral vascular disease. 45% are due to trauma, less than 2% due to cancer, and less than 1% due to congenital deficiencies. There are approximately 185,000 amputations that occur each year in the United States. There are more in third world countries just because of their war-torn status, and they have decreased medical developments there. There is a 5-year mortality rate after the new onset of diabetic ulceration after a lower extremity amputation. So about 43% to 55% will have a mortality rate if they develop a new ulcer. So this is really important for us as healthcare professionals who will be treating these patients multiple times a week, multiple times a day. So we're making sure that we're educating patients and caregivers on skin checks so that they don't develop new ulcers, because the outlook is not good. Patients with diabetes and lower extremity amputations, 55% will require amputation of the second limb within 2 to 3 years. So again, making sure that we're also educating on bilateral skin checks, because most likely they're going to be bilateral limbs will be involved, and so we kind of want to prevent the other limb from being amputated, because this really makes it difficult for patients to be independent and ambulate around with all the comorbidities that they'll have to deal with. So there are different types of lower extremity amputations. There's toe amputations, which is right at the toe, not at the joint, but just within the phalangeal joint. And these don't necessarily require any prosthetic. You can generally weight bear and walk fine on them, so usually therapy isn't indicated. There's the transphalangeal amputation or disarticulation, which the amputation is done right at the metatarsal. So if it's done at the great toe, it could affect a patient's push-off, so they might need some training, but they usually are good ambulators and they don't need a prosthetic. There's the transmetatarsal amputation. That's the yellow line right across the metatarsals, and that's a partial foot amputation. Sometimes they may require an orthosis. So what we'll do is they'll make an AFO, and they'll put an extension underneath it to kind of act as the foot, or they'll give them a rocker bottom soled shoe, so that can help with their push-off and dorsiflexion while they're walking. There is the Listrane amputation as well. That amputation is at the joints of the tarsometatarsal joint, and that is the disarticulation of all 5 metatarsal and digits. And that's kind of the same thing. They'd get the AFO or the rocker sole shoe as well. The Chopart amputation is at the talonavicular and calcaneal cuboid joints. This leaves that calcaneus and the talus, so they have no metatarsals left whatsoever. And then the Syme amputation is an ankle disarticulation. Sometimes they leave the heel pad at the bottom for weight bearing for comfort. And again, the AFO prosthetic might be something that we're looking at for these individuals. Mostly what we see throughout our network and what we've seen in an outpatient clinic are a transtibial amputation and a transfemoral amputation, so an above knee or a below knee amputation. If they're, so for our BKAs, our below knee amputation, this retains the knee joint, okay? And this is an important part for patients who are going to be ambulatory after with a prosthetic. If we can, we'd like the knee joint to be spared, because this will we'll expect less energy expenditure from the patient if they have their knee joint in place, okay? But sometimes that's not possible. And you can have some hip disarticulations where they lose the limb completely, or some hemipelvicectomy where the ischium, the ilium, or the pubis is removed. So stages of amputation rehabilitation, there are 9 of them. They start from preoperative treatment, so a lot of times when it's vascular, it's elective, so patients will have conversations with their vascular doctors, primary care doctors, cardiologists, and this will be a consented surgery. Sometimes when there's trauma, that's not always the case, but most of the time we like to make sure that we are letting patients know that we are removing a limb from their body and what to kind of expect when that comes. The second stage is the actual surgery, and then we'll go through everything one by one specifically. So preoperative, like I said, the consult with the physician and or surgeon if it's non-traumatic cause of amputation. It should involve patient education, what to expect throughout every phase of the process, what their functional progress is going to be, and what the timeline of each stage is going to look like. We should also be discussing, before it even happens, the amputation even occurs, the realistic short-term and long-term goals. We just want to make sure that patients are kind of aware of what to expect afterwards, so there's really no surprises, and that they're not thinking that they're going to up and walk and run right away, that this is a process and it's going to take some time, and they're going to meet a lot of health professionals along the way. And then resources for support. We want to make sure that we're guiding them to peer mentors, support groups, and psychologists, because losing a limb can have an effect on a patient's emotional status, and we want to make sure that that's being dealt with appropriately. The actual surgery, there's a couple of considerations when the surgery is performed. The surgical residual limb length discrimination is going to determine what kind of prosthetic we can give to these patients. So like I said earlier, we want to make sure, if we can, that the knee is retained, so that energy expenditure when walking is not as great as without the knee. Closure of the wound, we want to make sure that it's a nice suture, so that we don't have any open wounds or any risk to infections. And then also we want that wound to close as quickly as possible, because we want to get that prosthetic leg on as quick as we can to get them functional and moving. Nerve management, try to spare as many nerves as possible for muscle function, but sometimes this can be difficult because of pain issues, so sometimes the nerves do need to be resected, and so sometimes we might not get full contraction of that muscle because the nerves were damaged during the surgery. But that is something that is addressed during the surgery, and they try to spare as much of the nerve as they can. Dressing applications and limb reconstruction. So this is important. The way the muscles are sewn back, the way the skin is sewn together, and the way the dressings are applied afterwards are going to help how the residual limb is shaped. And the shape of the residual limb is very important for socket and prosthetic fit. So we want to make sure that, the surgeons want to make sure that they are doing their best to ensure that it's a nice conical shape limb so that we don't have issues with swelling or gapping when we start fitting for the prosthetic. So then you're going to go into the acute post-surgical phase. So right after surgery, what are our goals? What do we want to do? Range of motion and flexibility are going to be super important. We want to make sure that the patient's removing both limbs, especially the residual limb. We want to make sure that they're positioning the limb in an optimal position so we avoid contractures. If patients start not paying attention to their limb positioning, if they get a hip flexor contraction, that's going to make it really difficult to walk as well once that prosthetic comes on. So this is early on education, needs to start post-op day 1. Also, we're going to be doing strength of upper and lower extremities. Obviously upper because we need them to transfer. They might be using walkers and crutches in the beginning when they don't have a prosthetic training limb. We already talked to them about pain management and sensation management, functional mobility training, transferring, how they're going to get around on their own. Equipment prescription, again, do they need crutches, a walker, or a wheelchair? Do they need a sliding board? And then patient education, also family and caregiver education. How can the family help them? How can patients help themselves and make themselves as independent as possible in this stage of the process? In the pre-prosthetic stage, this is where we're starting to really look at shaping the residual limb. So I also mentioned too that the dressing during the surgical stage and is also during the acute phase 2 is patients will be wrapping their limb. What the wrapping, and there's a picture on the bottom. Wrapping the limb helps with a couple of things. It helps to shape it, and it also helps with edema control. So after the surgery, there's going to be a lot of edema down there, but we don't want that to stretch the skin and we don't want it pooling. So patients' limbs will be wrapped to help promote that edema flow out of that residual limb. And then you can see the top picture kind of shows how it's a little bulbous on the bottom where you have a nice straight residual limb to the left, and that's what we're looking for. So with the wrapping and stump shrinkers, that's prescribed after surgery. That, again, is to help with the flow of edema and to help with the shaping of the limb. Those are going to be 2 really important pieces that are also going to affect their care down the line. So I'm hoping you're seeing a theme here that what happens in the hospital will affect their outpatient stay as well. And so it's important for everybody to work as a team together because this patient is going to meet a lot of different people along the way. And if we're all on the same game plan, it's the best practice for these patients. Okay, and then again, they're going to go through skin care. And again, we're just kind of reiterating all of the previous education that hopefully happened before the surgery. They're going to have wound care. We're going to make sure that they're cleaning it. We're going to make sure that everything is closing. There's no signs of infections, and that they are healing. The training limb will also be administered at this point. So the first initial limb that a patient gets is not the limb that they're going to have forever. This is the limb that they're going to be practicing on. This is the limb that they're going to start shifting and weight bearing onto and maybe taking some step widths, but it's going to help them with their functional mobility too. So we're going to teach them how to transfer with this limb, how to just bathe themselves, use it to go to the bathroom, anything that they need to do to get around their house and to be discharged safely to home. And then at that point, home care will be working with them or skilled nursing facilities. So how they practice and how often they wear this training limb is really going to determine how well and how successful they are to get a new prosthetic and how the joints in that prosthetic are going to benefit them. And we'll talk more about that later. The training limbs right now are being administered about 8 weeks after a patient receives their amputation, just to kind of give you a time frame. So that's definitely allowing for that wound healing time. We're making sure that everything is closed, and then we're making sure that the residual limb is shaped and there's not a whole lot of excessive edema. There's going to be some edema. We just don't want excessive. And then continued focus on strength, range of motion, and aerobic endurance. Because we're missing a limb, there's going to be a lot more energy expenditure for gait. So we want to make sure that we are also focusing on their endurance and not just their strength, because they're going to need that. A lot of patients come into the outpatient environment and they fatigue out very quickly. So we want to make sure that we are setting them up for success in that area. And then patients are more prone to contractures during this period of time as well. So then you're going to have your prosthetic prescription and the fabrication. So there's criteria that needs to be met to receive the final prosthetic. Again, we want to make sure the wound is healed, that the edema is decreased, and there's stump maturation, which means that the stump volume is constant. So after surgery, between the shrinker and the bandaging, there's going to be some fluctuation in volume just because things are still healing. So we can't, and we don't want to give a patient their final leg, their final prosthetic limb, until all of that volume is constant, because we can't keep adjusting out the socket. Once the socket is made for them, typically insurance won't cover a new socket right away. There can be modifications that can be made to it, but we want to make sure that everything is constant and stable before we give them their final prosthetic. And then the team consensus to determine proper prosthetic to meet the patient's goals and abilities. This is determined by K levels, and it's generally assessed by an outcome measure called the AMP-PRO. It's something that we do in the outpatient environment. Our acute rehab therapists use the AMP-NO-PRO because at that point, sometimes they don't have their prosthetic, but it's still assessing their functional ability as an amputee. So, K levels, sorry, I know it's a lot of words and it's difficult to read. This is right off of Medicare's website. There are 4 different K levels. Determining how much a patient can do will determine what level they're at, and depending what level they're at is what kind of prosthetic an insurance company will cover for them. So a level 0 is they don't have any ability or potential to ambulate or transfer safely with or without a limb, and a limb won't enhance their quality of life or mobility. The level 1s, they have the ability or the potential to use a prosthesis for transfer or ambulation on level surfaces at a fixed cadence. So these are like your household ambulators. So they might not get the fancy computerized knees that control eccentric lowering, because if they're just a fixed environment, they're not going to need that. So the insurance won't cover that. If you have a patient that needs that, then we need to work with them in therapy to get them up to speed in order to demonstrate that they will be a level 2 or a level 3 so that we can get them the microprocessor or the computerized knees. So the level 2. They have the ability to ambulate and transfer low-level environment barriers such as curbs, stairs, or uneven surfaces, and this is typical of a community ambulator. A level 3 will have a variable cadence, so they can switch from fast to slow walking, and these are all things that are addressed in the AMP-PRO. So depending on how much of a functional level they can do, they get a score, and each score is related to a K level. Typical of the community ambulator who has the ability to traverse most environmental barriers and may have vocational, therapeutic, and exercise activity demands. And then your level 4 are for high impact, high stress. These are for your kids that are super active or your active athletic adult. Make sense? Any questions before we go on? Okay, great. Okay. Then after we get their fabricated prosthetic, we're going to do some prosthetic training, and this can typically happen one or two ways. We can either see them right in the outpatient environment, or if they need intensive therapy, we can try to get them readmitted back into the acute rehab center so they can do some more everyday intensive prosthetic ambulatory training. During this stage, we really want to address increasing that wear time. We want these patients in their prosthetic leg as much as they can so they can get comfortable with the fit, they can get comfortable with weight bearing, they can get comfortable with their daily activities. If there's pain, if there's swelling, wearing the prosthetic limb will help with that swelling, and it also will help the fit better. And if that is not working, then we can get the prosthesis out there and make adjustments to that socket if we need. But we don't know that if the patient's not wearing their limb. We'll teach them donning and doffing of the prosthetic limb, how to manage it, how to take care of it, how to clean it, how to check, again, the residual limb and how to clean that. And then gait, balance, endurance activities. And the higher the amputation, the greater the energy demand. We've reviewed that a few times. And then the last few stages is community integration and vocational rehabilitation. We want to resume their family and community roles. We want to get them back to doing what they were doing before. The emotional and peer support, again, making sure that we're providing opportunities for them to have these resources. The assessment for return to work-related activities and recommendations for job modifications if we need. So, some patients who are carpenters, used to climbing on roofs or going up ladders, this might not be a realistic goal for all of your patients, and so we need to make sure that we're offering job modifications for them. Okay. So that's just a little overview of how things should happen and how things are kind of happening here. But this is the St. Luke's University Health Network Amputee Project. So basically there's a group of therapists and one of our vascular surgeons, Dr. Lynn, who have all come together, and we've decided that this is a patient population that we need to better serve. There are therapists in the network that have experience working with this population. They have an interest, they have a passion for treating this population. So it's kind of everybody coming together and saying, okay, what are you doing in your setting? What are we missing? What do we need? How can we bring it all together? How can we work together so that we're making sure that these patients are getting the best care throughout the continuum at St. Luke's Health Network? So who's involved? Like I said, a committee of healthcare professionals throughout St. Luke's Health Network consisting of physical and occupational therapists who have experience treating patients after lower extremity amputations from each rehab setting. So we've had therapists from inpatient, the acute rehab, home care, and outpatient. We've had our vascular surgeon, Dr. Lynn, on board, and some case management. The objective of our amputee project is to establish and promote a standardization and continuum of both medical management and rehabilitation within St. Luke's University Health Network in order to provide best patient care status post-acute below-knee or above-knee amputations, because these are the most amputations that we're seeing and that we're educated in treating. So our mission is to assist our patients in achieving their highest possible level of independence through high quality, cost-effective medical and rehabilitative care. And some more purpose is creating a team approach, like I said, for the care of this patient population throughout all settings. We want to make sure that we're supporting all the other clinicians and all the other settings within our network. We want to mentor and provide training to the therapists throughout the continuum to establish confidence in treating this patient population and ensuring the consistency of care. We want to provide education to the patient and their caretakers, discussing the timeline of prognosis and what to expect during each phase. We want to develop a system for identifying patients in each setting and handing off from one setting to another. We want the rehab team to be responsible for their care and act as gatekeepers until an outpatient physician is identified, and we will talk more about that. And then we're going to track and continue to assess the needs of each patient as they progress through the network. And we're going to work with case management and the Amputee Coalition to develop community outreach programs and resources for this patient population. So the relevancy of the amputee program, it was identified that patients status post-acute below-knee and above-knee amputations did not continue their medical follow-up or rehabilitation care within St. Luke's University facilities. For fiscal year 17, there were 129 amputations performed by vascular. Of those, 41 went into our inpatient acute episode. There were 41 inpatient acute episodes here within St. Luke's network. 27 of those patients were seen on the ARC. 132 of those patients were seen at home care. Actually, there were 132 home care episodes, so more than what we performed here, which means that we're filtering in from other sources as well, which is good. But then there's only 19 outpatient episodes. So where are the rest of the patients going? So there's a huge drop there. There's a drop from the ARC. There's a drop inpatient, ARC, and outpatient. So how can we make that more efficient? How can we make that better? And how can we get our name out there? So some barriers we came up with that reduce the retention rates of this patient population across the network. One, and then there's also action plans to follow each of those barriers. There's a lack of patient education regarding the next step in their rehabilitative process, status post BKA or AKA. We found that patients who meet a therapist right after their amputee or before their amputee are more likely to be like, hey, I met so-and-so and I'm supposed to see them in my next phase, or this is the therapist that I'm going to see at my next phase, or this is what I'm to expect at my next phase. Patients were not getting really adequate education. They had no idea what to expect. It was kind of just all up in the air, and they were looking for those other networks that were going to show them their goals and give them an idea of what to expect. And so this was one of the areas that we were really lacking in. Also, our vascular surgeons, one of their feedback comments to us was they don't have any education to give to the patient. They don't know a lot of the answers about PT or what to expect. So it's hard for them to promote it when they're not well versed in it either. So our action plan was an establishment of a patient education binder. And there's a whole section on that we'll go through. So another barrier we came up with, the lack of medical professionals education regarding next step in the rehabilitation process. Our action plan is the establishment of that handout with flow sheets of recommendation rehabilitation status. So again, the patients are going to have a clear idea of who they're going to meet in their next phase, where they're going to be in their next phase, and what are the goals of the next phase. And then the management of this population, we're hoping to have some consistent case manager, nurse manager, or rehabilitation team follow up with this patient. Currently, right now, we don't have an outpatient physiatrist who is following along with these patients. That's technically how it's usually worked out, is that the physiatrist will follow up with the patient 1 month post-op, making sure that they have everything that they need. Do they have their stringer? Are they wearing their training limb? Are they going to therapy? So currently at St. Luke's, we don't have anybody outpatient following up these patients. That's another barrier. There was some talk about, can we get the primary care physicians on board within our network? But that would take a whole lot of time and training, and not every primary care physician is really comfortable or versed in treating this patient population. So that's another reason why we all kind of met together, and we figured that if we had some handoff between therapist to therapist in each setting, that we would be able to manage this on a clinical end ourselves, and then contacting a physiatrist or a primary care physician to let them know what we need versus waiting for a physician to tell us. Of course, there's pros and cons to all of that as well. A third barrier is lack of promotion of the St. Luke's Health Network, ARC, as compared to inpatient rehab competitors. So one of our action plans here is get accredited by CARF to have an amputee program so we can promote that and be established and get the accreditation for it, and improve marketing of our amputee rehabilitation program, both outlined and via handouts. If a patient is discharged to a skilled nursing facility, not all of them are being discharged to a St. Luke's University preferred provider. So once they got into another SNF, they would then be discharged to another health system. So we were losing patients that way as well. So we need to do some more education with our case managers, social workers on the importance of educating patients status post amputation and their family on why the facilities are preferred, why they should stay within the St. Luke network, and then who they're going to continue to meet along the way. So I talked a little bit about this before. We have a lack of an amputee coordinator or a physician or a point person that's going to continue to track this patient's care from the date of surgery all the way up until they're discharged from outpatient with their prosthetic. So it's a huge thing. So we really need to designate a physiatrist, and we really need to establish this role. That's a huge, and I think we're feeling that across the settings as well. That's a big piece we're missing. A lack of St. Luke's University Health Network outpatient rehabilitation facilities with amputee program. So right now there's Josh Kiner over at Warren, who is treating amputees. 8th Avenue is treating amputees. Tillman is treating amputees, and Quakertown is treating amputees. So there are 4 outpatient facilities that are treating amputees. We would like that to grow because obviously as an outpatient provider, we like to be close to patients' home. A lot of times we don't retain patients because we're too far, they can't get a ride. Patients have amputations, they might not be driving. So the more therapists that we can get trained and mentored to establish an amputee program in the outpatient would also be beneficial. And an absence of a standardized pathway in place to provide consistent best practice medical management rehabilitation for this population. And this is why we are doing the Amputee Pathway. So we want to make sure that we are using standardized care and we are practicing best practices. So resources we have in place now, which I kind of talked about a little bit. We have a patient information packet or binder. We have it. It's in the works still, but it's on its way to being complete. We have mentoring and e-learning opportunities. I'll talk more about those two. We have team leaders. We are in the process of identifying an outpatient physiatrist, not finalized, and we have a relationship with a prosthetist. And I'll talk more about that. In the works, we still need some specifications of an amputee clinic. We need to identify a counselor or an outside psychologist who's going to help with the emotional aspect of these patients. We need to design protocol and orders from the surgeon regarding wrapping schedules, showering, getting the incisions wet. I know that there's some question from our inpatients about when these things should happen. So we need to kind of have a definitive protocol with our vascular surgeons. And then also support groups and peer mentors and CARF accreditation. Any questions about any of that? We're good? Okay, so more about the patient education binder. Patient education binder was designed by inpatient therapist, outpatient therapist, home care, and acute care rehab therapist. The objectives were to outline the recommended rehabilitation process status post the amputation. It's going to serve as a tool that a patient may utilize to keep all of their post-operative medical and rehabilitation paperwork in one place, and it will be individualized based on each patient's needs and customized as they progress through each setting. So there's going to be a lot of the same stuff in this binder because it's something that they're going to get pre-surgery, so it's going to have a lot of information and education in it. But as the patient gets into inpatient, they're going to get all their handouts on how to wrap their residual limb and how to clean it, and then when they're going to get all their exercise information as they go along each setting, we'll put things in and take things out as needed. So each patient is different, so that it's not going to be the same for everybody. And then it's going to provide information regarding specific rehabilitation processes, like I just said, exercises, their prosthetic leg, who's going to give them the leg, when are they going to get the leg, how are they going to make the leg work, prosthetic management, all those kinds of things. We decided on a binder versus a pamphlet because we like the idea that a binder is not easily tossed aside. It won't get lost in a bunch of paperwork. It's actually something physical that they can have in their hand, and it's one of the feedbacks from our vascular surgeons. It's something that she really wanted because she thinks that it's valuable, and she wants patients to make sure that her patients have all their education on hand and ready to go. So again, the binder is going to include detailed information for patients, the role of each therapist in each setting, phone numbers and contact names for each patient at each setting, handouts, frequently asked questions. It's going to help to educate, like I said, and how and when they'll receive their prosthetic, and our outpatient location guides of the therapy offices that are currently treating patients post-amputation. Binder components, again, the handouts, some of the handouts like I mentioned, there's going to be handout on skin checks, management of phantom limb pain, desensitization, positioning of the residual limb, depression and anxiety, residual limb wrapping, home exercise programs, and the K levels. And so the K levels are going to be something that's going to be addressed at the very beginning so patients have a continuous understanding of what to expect and what they need to work towards to get the limb that they want. And that would be most beneficial for them. Each setting is going to have their own handout, and it's going to list the areas that are going to be addressed. It's going to list the goals and then what's going to happen next, along with the therapist that they will meet along the way. So there's a lot of words here, and it's a lot of things that I've said already that's repetitive, but the binder components for acute care, they're going to work on functional mobility, strengthening, participation in activities of daily living, caring for the limb, and coordination of care for discharge planning. The typical goals are to increase independence with bed mobility and sitting balance and transfers, improve strength of legs, arms, and trunk, improve ability to walk without the prosthetic limb or use a wheelchair, and increase ability to perform their ADLs, optimize range of motion of the residual limb, provide education on discharge planning. When the physician decides that they're ready to discharge from the hospital, they'll likely go into an inpatient rehab facility, hopefully over to our acute rehab center, to carry on their physical therapy and occupational needs. When they get to our acute rehabilitation PT and OT, the goals are going to be similar to our acute care. Their typical goals are to increase the overall strength, effective pain control, understand proper skin care, determine what equipment is going to be needed for safe discharge to home. I mentioned earlier that sometimes once patients do get their final prosthetic limb, they can be readmitted back into the ARC. And so those goals at that point would be learn how to walk with the least restricted assistive device. They're going to work on stair climbing transfers, skin and sock management, perform ADLs with the prosthesis. So here are some qualifications for ARC readmissions. And again, it's just for our therapy and all of our clinicians to have an idea. Once the patient receives their prosthetic, addition training in the rehab setting may be needed. Sock management, prosthetic wear, and fit treatment for complications and other comorbidities. I said a lot of this already. Justification, we need justification for both PT and OT services. So you need to somehow justify that your patient needs both skilled services. PT usually addresses the transfers, walking, and stairs, and OT will generally address the donning, doffing, as well as self-care and ADL tasks. If you have a patient with a prosthetic limb and you think that they might benefit from a readmission back into the ARC, these are kind of the criteria we're going to look for, and I'll get more specific. We'll need a script from the physician saying that they need to readmit into the ARC, and the most recent MD notes to help prove medical necessity. They'll want to see recent labs, the date of the amputation, comorbidities currently being treated, and recent medication list. We'll also need some stuff from the clinicians. That's why your documentation is really important and you have an understanding of what your patient's needs are. Contact info for the treating therapist, if they currently have their prosthetic, how long have they had it for, and who is their prosthetist, because if any adjustments need to be made, we need to know who to call. Transfer and mobility status, ability to complete self-care tasks, ability to don and doff appropriately. Equipment that the patient is using, information regarding their home setup. Are they going to get a ramp? Are they getting modifications? Or are they just going to try to be independent with what they got? Any other medical issues, cardiovascular function, information regarding their prior level of functions, current skin issues, and insurance information. That's always a big one. Binder components for home care. So if a patient gets discharged to home, they don't go to a skilled nursing facility. They're going to be expected to work on functional mobility. All their transfers are walking and use of wheelchairs. Keeping up with that strength. Participation in activities of daily living within their own home using their own equipment. Caring for the residual limb. Strategies for home safety. And again, coordination of care that's interdisciplinary. A lot of the goals are the same, but one of the major ones is avoiding that rehospitalization due to comorbidities. We don't want to see our patients back in the hospital, or we want to make sure that we're educating on skin checks and lower limb of the other skin checks on the other limb so that they're not going back to the hospital to have that leg amputated as well. What happens is sometimes when our patients don't get a training limb or they're not using it and they are not practicing safely and they are hopping around, that puts them at risk for more breakdown on the other side as well. They're putting a lot of pressure and a lot of stress on that other leg, and so if we're not educating them on that and if we're not teaching them how to properly do things, then they might be back in the hospital with other complications. And then what happens next is a variety of things. If the patient has gotten their limb at this point, they have good volume, consistent residual limb, it's constant, and they have gotten their prosthetic, they might be readmitted back into the acute rehab center to work on that ambulatory training, or they might be appropriate for outpatient. So in their outpatient environment, we're going to work on, again, more desensitization and pain management if it's still there. Scar mobs, donning and doffing, and a wear schedule. We're going to make sure that they're wearing this limb and that they're using the limb. We're also going to train in fall, recovery, and prevention. Yes, we do not want our patients to fall. We do not want them to injure themselves. But is that a realistic goal of a patient with a prosthetic? Probably not. They're going to fall. So we need to teach them how to fall and how to get up from a fall and how not to hurt themselves when the falls happen, and improve their overall endurance, progress their exercises as needed. And the typical goals are really based off of the things that I just said. Okay, so then in the binder, after we have all of our what to expect in each setting, we're going to have our prosthetic tab. There's going to be all local prosthetic vendors. There's going to be flyers and business cards for everyone. The prosthetist will review the actual joint components and the sockets and the foot prosthetics that they can offer to the patient. It's not something that we're going to leave up to our clinicians because the prosthetists are the experts in that. There's tips for choosing a prosthetist in there as well. We do have a relationship with MedEast. We do use one of their certified orthotic and prosthetic, but we want to make sure that they don't take everybody's insurance. So we want to make sure that we're making resources available for patients with their insurance type, and we want to make sure that we're giving patients an option. They shouldn't feel that they have to use a certain vendor if they've used another vendor for something else. So we want to make sure that we have all the resources available to these patients that's close to their home. And more resources tab, we're going to give them the website for the Amputee Coalition, the preferred providers for our skilled nursing facilities, financial resources, financial aid and grants to help pay for the prosthetics if their insurance isn't going to cover the whole thing, and then set up for success, ask for discharge from our system. Any questions on the binder or patient education?
I have a question.
Yeah.
So you said it's like 8 weeks before they get their training.
Their training one.
So is there any time where people can go to outpatient before that, or you guys basically see them once they have their training?
So we are currently seeing patients when they have their training limb, which we'd rather see them when they have their actual prosthetic limb. So we'd rather, the training limb would be nice to happen in the ARC or with home care.
What if someone's just discharged to home? So from the time they get home to those 8 weeks until they have it, are they just getting like home care the whole time?
When they're discharged?
Like discharged from the hospital. So say they didn't
Yeah.
go to the ARC at all, they just went right home. Are they receiving like home care for that full 8 weeks to like take care of the stump wrapping and like maintenance?
Yes, yeah. As long as they need medical management, they're going to be having home care
But they generally
therapy
don't
there.
come to outpatient before that.
They generally don't come to outpatient before that. Yeah, it's all that. We usually don't see the patient. They usually come to us with the training limb right now. And so what's happening is we see patients with training limb and they're still having volume issues. So we're still dealing with socket fit. So there's socks that patients put on to help increase the girth to get into their socket, because likely that training socket is made when they're swollen. So it's going to be bigger than what their residual limb is going to end up as. And so we are playing around a lot with fit of the socket, removing socks, putting socks on. How does it fit? Are they all the way in it? So we do spend a lot of our sessions playing around with that versus actually doing like functional walking and stair tasks. So if we could get them to get that training limb when they're in acute rehab or at home care, and they can work on that and get the volume consistent, and we can get their final prosthetic leg, we can do a lot more of that ambulatory training in the outpatient environment. Not that we're not doing it, but we do spend more time. And so it eats up their insurance, it eats up their visits, their co-pays, the authorized visits, so their limits and stuff. So to answer your question. Any other questions? Yeah.
I was just wondering, like when they're ready for their initial prosthetic, for the training prosthetic, does the physician usually tell them and write them the script to contact the prosthetist, or?
So we work with the prosthetist. So what happens is I'm sorry, did I cut you off? Did you have more to that? Okay. So usually what happens, yes, we will need a script and from a physician, which is one of our hurdles that we need to jump through. But usually the prosthetist usually comes in on day of eval, and they'll call us and say, I saw so-and-so in the hospital, they're going to come to you. And what happens is we'll do the eval, we'll see how things are fitting, we'll see how the wear goes, we'll work with them in therapy for a little bit, and then I might say, hey, this socket isn't working, or they're not getting down all the way, can you make some adjustments so that we can get into walking? Or we might say, hey, this guy looks great, he's been coming in with only 2-ply socks for 2 weeks, it looks like the volume is controlled in his residual limb, we're ready for a new prosthetic. We'll get the ball rolling, we'll let the prosthetist know. He'll come in, he'll do an evaluation with you in the clinic, and then get the ball rolling that way.
Okay. I just wonder what the initial, the one.
The first one?
Yeah, the first one.
What? Sorry, so what was the question?
Or as far as the process do they contact the physician? Or do the physician
so the physiatrist should be seeing them in the hospital or wherever they are when they're ready for their training limb. Yeah, and a clinician can contact the physician and say, hey, listen, I think they're ready or everything is healed, or it happens with one of their...
Do you recommend just measuring the residual limb and just see how much fluctuation there is?
Yeah, so that's one of the things we're going to get to next, or it's coming up. But so we've talked about designing like an amputee tracker. So I know with some of our other patient populations, like we have a stroke tracker. And so we're tracking some scores for our stroke patients across the continuum. We want to do the same thing with our amputee population. So when they start in acute, they're going to start with girth measurements, and that's going to be tracked every day. And then when they get to the ARC, they can show that the girth is going down. But it's also how many socks they're using too. That's also another measure of their volume control. So it's something that we're in the works of still working towards. Yeah. Anything else? All right. A few more quick things here. So we've established team leaders in each setting. They're designated physical and occupational therapists identified across the continuum who have experience treating patients with lower extremity amputations. These are the go-to persons for questions. Any clinician that has questions, if you're a clinician in another setting and you want to know what happened with your patient in the previous setting, or if you're a clinician and you have questions about a patient, you're going to ask this person. They are the ones with the most knowledge and the most experience in treating this patient population. They'll be the mentor in their respective settings that help to train other clinicians. So anybody who's interested in treating this patient population, you can undergo training and mentoring with these people, and they're going to act as the liaison for passing along the information from one setting to the next. So they're going to complete that amputee tracker. And the amputee tracker, we just kind of talked about this. So I don't think we really need to go through it. Again, these are your team leaders. Okay, these are our established team leaders. In the inpatient environment, we have Jess Hartman, who's Jess Marks, I'm sorry, and Kelly Fernald. And then in your acute care, we have Georgia and Megan for PT and OT. Home care, Marcus Smyrner is our go-to right now. And in outpatient, we've got Vanessa at 8th Avenue and Josh over at our Warren Balance Center. All right, therapist training and mentoring opportunities. These are for all clinicians throughout each setting interested in treating this patient population. So if you are looking for more clinical information on how to treat this patient population, this may be a good opportunity for you. They're designed to educate the best practices to ensure consistency of care throughout our network. We will have the opportunity to complete lecture and skills lab. There will be e-learnings eventually provided, so all the lectures that So basically, Josh and Vanessa, our outpatient therapists, have put together lectures. They're in PowerPoints. We're going to do some voiceovers and then hopefully make them into e-learning so that we don't need to hold mentoring sessions, once every quarter or whatever. Clinicians can do it self-paced. If you have a new therapist that comes on and they want to treat this population, they can hop on their e-learning and learn more about it. There's also going to be videos for stump wrapping and transferring and all that fun stuff. And then eventually we'll develop competencies. So Vanessa has developed our acute care PowerPoint. Vanessa comes to us from the University of Pittsburgh Medical Center, and she went through their amputee competencies and programs on the inpatient side. So that's kind of her area of expertise, but she's also treated them on the outpatient side as well. So these are kind of her goals in her PowerPoint. And then Josh. Josh has worked with our veterans with amputations. He ran the amputee program at the 8th Avenue Clinic for a year or two and is now doing it at the War and Balance Center. And he's also an adjunct teaching for the DeSales program. So he is doing more of the outpatient-based treatments. You're going to get more of gait analysis and socket fit and what outcome measures to use and evaluations. And here are some references and resources. So the below is the Amputee Coalition. If you are treating patients with amputations and they need a resource, that's a really good resource. They do have peer groups. It happens once a month, and they're right in Allentown for our Bethlehem Lehigh Valley folks. So that's a good resource. You can go in there and kind of navigate the website. And a special thanks. So these are all the people that helped out in making the Amputee Project happen. Like I said, it's a series of clinicians and Dr. Lynn, who's our vascular surgeon. Everybody has played an integral role in this, whether they were part of the binder committee, making up the lectures, acting as a mentor, or a manager helping to make this flow of care happen. Any more questions? Okay, that's it.
Let me check to see if they have any online. Anybody online have any questions? So, actually, I do have one question.
Okay.
How do you guys, you're working with these individual people. Are they just supposed to contact them via email or via phone, or is there a particular preferred pathway that you guys want to go through for enhancing communication?
So I always think that email is easiest in the outpatient world, but I don't know how our inpatient therapists feel, so if you guys kind of want to chime in. Email?
I would say email is probably the best.
Marcus, email. For home care, inpatient, email. Email.
Okay, and then lastly, how do you feel patients are going to benefit? What are patients going to benefit most out of this?
Well, I just think the continuum of care, and I think if we establish this program, it's going to be the best practice. We're going to keep patients within the network. We're going to make them happy because of the consistency of care. We're providing that education so they know who they're seeing along the way, and we have our therapists along the line saying, now you're going to meet with so-and-so. They're great. They're going to help you do this, this, and this. I think that's where patients get lost a lot because it's not vested in them, but we're going to vest it into them, whether they like it or not.
All right. Well, thank you very much.
You got
Anybody else
it.
have any
Thank you.
questions? All right.
Thanks.